I think you saw from the data that Mr. Chigayo shared on fetal defects that fetal heart defects are weakly diagnosed or are grossly underdiagnosed in our population. But we know from global data that fetal heart defects are the commonest defects. So it is on this background that I want to just talk about fetal heart examination. But before I do that, I just want to test those who do scans to find out where they are. Again, we're not going to mark you, you mark yourself. I'll play you this short video. In that video, there's nothing there which is frozen, guys. It's a live scanning. What you are seeing is what it is. So don't think there's some slowing of the video. The video is what it is. This is a live video we took on one of our babies we were scanning, and I've just thrown it there. And I'm saying, what do you think is abnormal about that baby? It's a heart. Then the next one, oops. Right, so that's the next one there. Again, it's a 4-chamber view. What is abnormal about that heart? If you see more than one abnormality, you can go ahead and list every abnormality you can see on that heart. Then overall, you should tell us what you think is the diagnosis. The diagnosis of the condition shown on the picture. I'm just hoping these videos are playing on your side. Admin, just confirm, are the videos coming through or I could be talking on my own? Admin, are we getting the videos on?
Yeah, we are getting the videos, Dr. Verenga.
Okay, thank you. So I'll go to the next one. This is the next video again of one of our patients. Again, what is list the abnormalities? There are about 5 abnormalities. It's just a 4-chamber view because I think this is where we need to start as a country to look at the 4-chamber view properly. Because outflow tract, I feel this is important because 80% of the fetal defects will be identified by a proper examination of the 4-chamber view. So list 5 defects that you can identify. Don't say, why is it moving? Fetal echocardiography is better to interpret a moving heart than a still heart. Because if I made this video to stop, it will look totally different. You may miss some of the things that we are seeing as the heart is moving. And finally, what do you think is the pathological condition here? What is the underlying heart defect we are dealing with in this case? Right, next. This one, what is the condition? I'm sorry, there's a shadow coming on this one. I think this one is a little bit slow, but just mention the cardiac defect. We are looking at on one of our babies as well. There, right. Then I think I should be done, but let's see. Probably I have another one. Right, there is another one. There is the other one. Oops. What's happening to this one? Oh la la. So this one is refusing to play, but this is the heart. I'm not going to bother you with this one because it's not playing. So I'll jump it. I'll go to the next one. Let's see if the next one will play. Oh la la. So this one is refusing to play again, but let me see the color one. I don't know why these ones refuse to play. Anyway, I think this is the end of the pre-course test for the cardiac talk. I will go to my presentation. Just bear with me as I share with you another screen. I'll come back with this presentation later on, with the pre-test later on. I will just share with you the presentation of the day. I will not be very long with this topic. I feel I just need to emphasize the 4-chamber view more than anything else. The talk is mainly on just examining fetal heart, but I've used my slides for fetal echocardiography. I thought it is important for me to just remind everyone that there are certain category of patients that need a fetal echo, not just examination of the fetal heart under a normal fetal anomaly. And who are these candidates? So anyone with a suspected cardiac defect on routine scan, they need a fetal echo to diagnose and to prognosticate the condition, and also counseling. Any baby who has an NT during the first trimester scan, which is above the 95th centile, remember, an abnormal nuclear translucent is also a screening tool for cardiac defects. So remember this, it's very important. Then family history of congenital cardiac defects. When we are talking about family history, remember, we're not talking about the mother's family history. We are talking about the baby's family history. The baby in the uterus is our patient here. So when you are saying first degree relative family history, please, I should have put in bracket first degree relatives. It is only the first degree relatives that increase the background risk of a cardiac condition to the baby, not to the mother. So if the mother comes and tell you that, look, my sister or his sister, he has a cardiac condition, it doesn't increase the background risk of this unborn baby. It is only if the mother herself, the one who is carrying the baby, and the father of the baby, the one in uterus, the father of the baby, or other siblings, that means brothers and sisters of that unborn baby, if they were born with a cardiac defect, that will increase the risk to this baby to about 3 to 5%. That will become the background, which is a very high risk, considering that millions of women deliver every year. So it's a very high risk, 3 to 5%. Then diabetes mothers who are on insulin need a fetal echo, because we know that endocardial cushion defects, they occur at an increased frequency in women whose diabetes is not well controlled. So women who are on insulin deserve a fetal echo, a proper examination of the heart. Then women who have lupus with positive and antiro and antilar antibodies. It is important that if you are looking after women with lupus, that you know whether they are positive for antiro and antilar antibodies, because we know that they have a potential to cause heart block. So it is important that the antiro and antilar antibody status be known. If they indeed have them, then they will need a fetal echocardiography and they will need a fetal heart surveillance. That means even if we do a fetal echocardiography now, it's fine. They will need a follow-up of that fetal heart to make sure they don't get heart block, which may compromise the baby's life. Ideally, fetal heart examination should be done for every woman. That is fetal heart examination. But in the context of fetal echo, if there is a high risk for a cardiac defect, we can start as early. Of course, at 11 to 13 weeks, we examine the heart, but we cannot make any conclusions on which we can make a pregnancy care decision. If we suspect that the heart doesn't look normal at 12 weeks, we ask these women to come at 16 weeks. Then we check their heart properly. So we can start as early as 16 weeks. But most women who are not very high risk, we ask them to come at 20 to 22 weeks to examine the fetal heart during their normal scan. And what are we looking for? It's not just the cardiac defect structural. We also want to make sure that there are no arrhythmias, There are no situs abnormalities, and of course, the structural defects of the heart. And whenever you are doing a fetal heart examination, always think of these things, that this is what you need to do, to look for. So knowing how to do a fetal heart rate properly is important. Sometimes people just look for something which is beating within the baby's chest. They put the pulse wave gate, whatever tracing they get, all they want to do is to measure their heart rate. But if you practice like that, unfortunately, you are going to miss a lot of fetal cardiac arrhythmias. So what is the approach? First of all, ideally, we want to just know the rate and the rhythm. If you are just doing a routine fetal heart, you want to know the position of the heart and also the abdominal situs. You want to make sure that organs that are supposed to be on the left side of the baby are indeed on the left, and those that are supposed to be on the right are indeed on the right side of the body. Then we want to check the great arteries, the left outflow tract, the right outflow tract, and the arch views. And of course, we want to do cardiac biometry and Dopplers. I'm not going to cover cardiac biometry and Dopplers because this is just a routine fetal heart examination expected during the anomaly scan. I'm not going to cover in detail the great arteries in the arch views. I'll just pass through them because I still feel as a country or as Africa, we are still struggling with doing the 4-chamber view itself. So we need to get it right on the 4-chamber view so that we can at least pick 80% of the defects. For now, we can take 80 rather than to take nothing. Then we'll come back for the outflow tract to take the other remaining 20 another time. So basically, I think there's somebody with who is that somebody with a mic on? I think it's the Fetal Medicine people foundation. Yeah. All right. So I've muted them. Let's continue. So when you are doing the scan, you know that from abdominal circumference, this is the abdominal circumference. If you look at these planes demonstrated here, these are straight planes. You don't have to do much to move from the abdominal circumference to go to the position of the 4-chamber view. Of course, you need to play with the probe a little bit to get the left outflow tract and to play with the probe in terms of rotating it again, the opposite direction. You rotate the left for the left to get the right outflow tract. And you just need to continue going towards the baby's neck in an oblique way where you look inside the baby, you get your 3-vessel trachea view. Like I said, those will not be the subjects of my talk today. I will just stay with the 4 chambers. I'm not going to spend much time here, but to just show you that they are common. This is our cohort, not many patients there, but we have an updated one, which we'll share with you another time. So if you look at our cohort, it was the second commonest defect, but if you look in the international literature, it's the commonest defect. The reason why it is second common in our case is because our screening protocol, or people who are screening, probably are not well versed with screening for heart defects. I think that's the most plausible explanation. And it is easier for most people to pick a ventriculomegaly than for most people to pick an asymmetry of the ventricles. So this may explain why we have these figures which sort of differ from others. This to just triage them, to just show you the common things, okay? Commonly, AVSDs are common. We have some tetralogy, we have arrhythmias, VSDs, aortic stenosis, hypoplastic left heart, and others. And out of our present day, of our cases, what we noted is that almost more than 2/3 of our cases were just picked by just doing a 4-chamber view. We could suspect them that by doing a 4-chamber view, but unfortunately for the other third, you needed to do more views. This is the argument which we always say that we need to learn to look at the fetal heart beyond the 4-chamber view. It's not good enough to just say I can do a 4-chamber view. There is more you can do to increase the detection rate of fetal cardiac defects. But like I said, today I want to zero in on the 4-chamber view because we want to do it right. Because if we start there, we improve. So when we have a 4-chamber view, how should we do a fetal heart rate? How should we do it in the right way? So your pulse wave gate should always be less than 2 millimeters. Should not be more than 2 millimeters. Within the 4-chamber view, which is a very good 4-chamber view, like we see on the screen here, you have to put your pulse wave gate just inside the ventricle, just on top of the AV valves. In this case, I'm putting it just on top of the mitral valves there. But as I'm putting it on the mitral valve, I'm trying to put it very close to the interventricular wall here, the IVS, the interventricular septum, so that I could capture two things there. One, I'm capturing the inflow of blood into the heart. Two, I'm capturing the outflow of blood into the heart. So that means I'm able, with this kind of heart assessment, I'm able to comment on the rhythm, whether it is a sinus rhythm or it's not a sinus rhythm. How can we do that? If you look, this is blood flowing into the ventricle. So we have the E and the A wave, which is the passive and the active filling of the ventricle. Then the other waveform you see is part of the outflow tract as blood flows out of the ventricle. So if we are going to have a situation whereby every arterial contraction is being followed by ventricular contraction, arterial contraction, ventricular contraction, then in this case, we know that the heart is beating at a sinus rhythm. If the heart was not beating a sinus rhythm, with a sinus rhythm, you will see on the other images. And of course, we have to measure the heart rate to make sure that it is within appropriate for gestational age. For the basic, I think this is what we need to know. Whenever we do the fetal heart rate, we should not just look for any part of the baby's heart, as long as there's some activity, and we just go on and measure the heart rate. Measure the heart rate in a way that helps in screening for fetal abnormalities, which in this case are fetal arrhythmias. I'll move on to the next. This is just show you some of the fetal arrhythmia. This is a case of fetal bradycardia. There's no slowing of the video here. The way the heart is beating is how it was beating. I'm not sure if we have a video of where we measured it, but you can see that there was bradycardia here, some sinus bradycardia on this baby. I'm not sure if this was the case of lupus, but we tend to get quite a number of these sinus bradycardias. I'm not sure which case was this one for this one. I think the other one is again another case of, let's play this video. No, not this one. This one is another abnormal case. Is this video playing? Let's see. Something has happened to this video. It doesn't want to play. I wanted to show you again another case of arrhythmia, but let's move on. Let's look at this one. So the baby came, we did exactly what I was teaching you there that we have to do. You can see our pulse wave gate within the mitral valve in this case. You can also alternatively put it on the tricuspid, but it's always easier to put it there. So you can see here that we are trying to see if this baby indeed was having a sinus rhythm. So because the heart is in the basal view, so expect the arterial waveform to be down here. So we can see here that here it's okay, here it's okay. Then somewhere here, the waveform seems to not to look normal. Here, it doesn't look normal. And then you follow again here, probably not looking normal, normality is restored. And we see another small waveform there. This baby had ectopic beats, but these ectopic beats did not affect the overall heart rate. It was 123 at 36+6, which is within normal for that gestational age. But the way ectopic beats with this baby, which would mean that some of the ectopic beats were not going through to give us a proper ventricular systole. So this is how it works. Then again, for this is the same baby. So we're now measuring the velocities at the aortic valve here to just illustrate to you that ectopic beat. You can see that there's a missed beat there where the ventricle actually doesn't contract due to these ectopics, which are not going through. So this is an example of a skipped beat, which you can identify if you measure the heart rate properly. But if you are going to just throw your pulse wave where there is something that is just beating, there is no way you are going to make this kind of diagnosis. And in most cases, these babies may be sectioned for an irregular heartbeat if proper assessment is not done. So this is how serious these issues are, that if the heart rate is not properly done or the heart rhythm is not examined, obstetricians will do a knee jerk. If the baby's heartbeat is not okay, a section should be done, which is fair if you don't know what you are dealing with, because sometimes this may save the baby. Then here we are again. We are trying to assess this baby's heart beating. You can see that we have a dissonance here. Look at the atria. Again, this is a basal view, so you expect them to be here, but you don't see a ventricular contraction. Atria, there is no direct ventricular. And look at the ventricles, the outflow, which is being picked here due to ventricular systole. You can see that these two are totally disjoined. There is no communication between the atria and the ventricular electrical activity in terms of the heart beating. So in this case, there was a complete heart block. They were not in sync. Each one was beating at its own rate here. So this is another example of a fetal. Look at this is fetal bradycardia, and there is total disjointedness between the two. We normally see this in cases of lupus with anti-ROY and underlying antibodies where there is blockage of communication. So that's how to assess the baby's heart rate in a proper way. Then we go to situs abnormality. How should one assess the situs? How do you know that their heart is pointing in the right direction and the organs of the baby are arranged in the normal way? Because it's just part of routine heart assessment. First of all, you should identify the baby's left shoulder, see where the left shoulder is. Once you are certain that you have seen the left shoulder, the next step is to look for the stomach and say, is the stomach to the left as it should be? Then you also have to look for the aorta and the inferior vena cava. I'm not sure if my image is showing nicely, but let's just see if I can show you. That's the aorta there. You can see the aorta is this one, the inferior vena cava is there. The great vessels, the aorta is to the left of the spine, while the inferior vena cava is anterior and slightly to the right in their arrangement with each other. They should never travel along each other or close together, these two big vessels. If you see two big vessels close to each other, the other one won't be the IVC. In most cases, it will be an interruption of the inferior vena cava with a zygous continuation. So you see the stomach to the left. When you continue to scroll down, you see that the heart apex is pointing to the left. You can do this within 30 seconds. After you have finished measuring the abdominal circumference, all you need to do is to scroll and make sure that the heart is indeed pointing to the left as it should be. If it's not pointing to the left, then things are complicated. Then that person will need a fetal echo now by fetal medicine. until we have fetal pediatric cardiologists. So very easy citers, but in most cases, the patients we have diagnosed with either dextrocardia or those with left isomerism, with heterotaxis with left isomerism, most of those cases were missed. They are actually reported as normal because this simple maneuver is not being done the way it should be done. So if we do it properly, it is very easy to see that, look, the heart and the chest are not pointing in the same direction. These are just two images to just show you there. Sometimes make it your scanning protocol that you always try to show the baby's stomach and the heart this way as part of the images you store. And you can see here we have the spine and the inferior vena cava. You can see the inferior vena cava is to the right of the spine, and the aorta, this is the spine, here, the vertebral body, and the aorta is more to the left. This is the adrenal gland, and this is the stomach. So you can see the heart apex here, that they are both pointing in the same direction. So this is correct. Look at this one of our case. Using the same maneuvers, just try to follow what is happening on that image. Oh, no, this one didn't show the heart, but there's something very interesting, which when you look carefully, you are going to see. If you look at the great vessels in that image, you are going to see that there are two big vessels close to each other, a situation we said should never happen. You can see here that if you look here, this is the aorta, but there is another vessel just behind the aorta on the right. This cannot be the inferior vena cava. The inferior vena cava should be somewhere here. So in this case, there was, this is an azygous vein due to the interruption of the inferior vena cava, which we see in heterotaxic conditions. So this is abnormal. So situs goes beyond seeing the stomach. You should also see the relationship of these big veins, vessels, that is the aorta and the inferior vena cava. If you don't find the inferior vena cava, then there is a serious underlying cardiac abnormality. They need to be referred for fetal echo. Other cases, which are often missed when patients come to us, to be honest, the patients who had diaphragmatic hernias we diagnosed, I think out of close to 10 of them, maybe only one, they'd been identified as having such. The reason comes from exactly the same videos I showed you from the beginning that should make a sweep and check the relationship of the heart and everything, because congenital diaphragmatic hernias invariably shift the heart position or the stomach is shifted. So look at this one. You can see we are trying to get the heart. You can see the ventricles depicted the color there, but all we are seeing now is that there is a bubble in the chest and the heart is squashed to the corner. So this was a case of a left diaphragmatic hernia which pushed the heart to the other side. This is the left congenital diaphragmatic hernia here. We are seeing, sorry. Then we have another case again here. You're trying to get the heart. You don't find it where you expect to find it. All you are now seeing is the heart squashed again to the corner. These are the ventricles. And you see a bubble, which in this case is the stomach. And you can see this structure here, the consistent, the echo appearance of it, that this is the liver. So this is one of the ugly congenital diaphragmatic hernia where the stomach and the liver are all in the chest. Very easy to identify if you follow the right protocol. But if you don't follow the protocol and you don't bother to check baby hearts, all you want to confirm to the mother is that there is a heartbeat, surely you overlook all these very, very bad defects, which in our case, probably they are close to lethality. because we are not doing balloon insufflation yet, endotracheal balloon insufflation. So we are not offering that. So these babies, we have nothing to offer them. So all we do is we calculate the lung head ratio to try and come up with a prognosis to know whether we should offer them termination or offer them hope. So very easy to diagnose by following the protocol. Let's go to the heart itself, 4-chamber view. I'll play the video. So when you look at the heart, how should we then look at it? The heart should occupy between a third, but not more than a half of the surface area of the thorax. And the apex should be seen to be pointing to the left of the heart. If you draw an imaginary line from the spine to the sternum, it should be seen to be pointing to the left. On top of that, you should make sure that the ventricles appear symmetrical. These ventricles, they should appear symmetrical. And the left atrium should look morphologically the left. You should see these vessels. These vessels are the pulmonary veins here, which are draining into the left atrium. And the right atrium, as rounded as you see it, is the way it should appear. And within the right, because after having done that, to go a step further, you should also know the morphology of the heart. When you are saying morphology, you are saying how should the heart look? How should the left side of the heart look? How should the right side of the heart look? The left side of the heart should be filled. Sorry, let me do the pointer thing. Laser. Yeah. So the left side of the heart should be seen to be apex forming. In other words, it should go all the way the left ventricle, and the right ventricle of the heart should be seen to have this band of tissue, which is sort of obliterating its end here. The tip of it is being obliterated by this band of tissue, which is called the moderator band. The valves should open and should not appear thick, abnormally thick, these valves here. And the offset of the offset of the tricuspid septal leaflet should be lower or towards the apex compared to the septal leaflet of the mitral valve here. So, and the lungs should be looked at, and they should appear almost symmetrical. If you are going, of course, the left always looks smaller because the heart is tilted that side, but you should see good amount of tissue both sides of the lungs, as you see. And the aorta, the ascending aorta should be seen here nicely as a single vessel. You should not see two vessels at this level. If you see two vessels, this vessel here, then there is a problem. So this is how the heart should be looked at when you are doing a 4-chamber view. How can you obtain this image? If you transition from the 4-chamber, from the abdominal circumference plane in a straight line without angulating your probe or rotating your probe, you will arrive at the 4-chamber view. Of course, you need to do some twists and turns to make sure that you are covering just one rib. You are not cutting through the ribs, because if you are cutting through the ribs, you will be oblique. Interpretation of the heart is only based on obtaining a correct plane of the heart. If your plane is wrong, you are going to make wrong interpretations, or you are going to see wrong things. The interventricular septum should be seen throughout. This is not the best plane to examine the interventricular septum. If we have VSDs, we have to go in what we call the septal view of the 4-chamber, which I think is beyond my talk today. I will not bother you with that one. Let's move on. Let's show. Now I think I have to show you some defects. I will not show color. I won't bother you with the colors. I just want to show you some abnormalities of the 4 chambers, just the 4 chambers. That's where my presentation just show you how to measure the axis if you are concerned, but this is not part of routine examination, just some abnormalities. Look at that heart. Remember, I told you the heart should not be more than half. And when you look at this heart, there is some element of dilation, that the heart, there is some dilated cardiomyopathy here with a thin rim of pericardial effusion. We normally see this kind of appearance in babies with severe placenta insufficiency, where the umbilical arteries are so high and the baby's heart is overworking to try to push blood to the placenta. So we normally see this kind of appearance in those conditions. This heart, is this a video? Let me see. Sorry, I just want to make sure if it's a video, I can play it for you. So if we look at this heart, this is the feeling. We can see that there is an asymmetry of the two sides of the heart. The right ventricle looks bigger than the small, but in uterus, always remember that what may appear small is the one likely to be abnormal than what may appear big when you're talking about symmetry. Of course, there are situations where it is not like that, but what happens in the uterus, due to the anastomosis and so forth, the heart, which is the side which is obstructed, does not enlarge like what happens in adult life, in extrauterine life. The side which is obstructed actually atrophies and becomes smaller. So, which is different from adults. If you have a blockage on the right side of the heart, the right side will balloon, but in uterus it shrinks. So you can see the heart there. That's we suspected coarctation of the water on this baby here. Let's go to another 4-chamber. Probably this video will play this time around. Will it? I wanted to show you this video. But anyway, this video is the same one with this one. This baby is a complex cardiac defect. We don't know whether the baby had 3 chambers, as you can see there, but this was the feeling of it. What we could see is that there was a large ventricular septal defect here, and the left was feeling nicely, but the right wasn't feeling nicely. So we suspected tricuspid atresia because you can see there's a valve which is not opening here. This valve is not opening the way it should. So we ended up with a diagnosis of this one is the atretic valve here of the tricuspid. So this was a case of tricuspid atresia. Let me move on to the next slide. I think my time is almost up. I need to round up. Right. Look at this one. I will not show you the color one. Look at this heart again. It's globally large, severe cardiomegaly. When you look now at the AV valves, you can see it's abnormally thick. Remember, I said this should never be abnormally thick. Here it is. And these valves will be leaking. This is the jet you are seeing there, the regurgitant jet, which if I turn it on, you are going to see a lot of red flow due to the regurgitation or blood in that jet. And you can see there. So, and the valve is inserted way, way lower than it should be, the septal leaflet of the tricuspid valve there. And this is a case of Epstein anomaly. Epstein anomaly. It's a lethal condition in this setting because you can see the lungs are gone. There are no more lungs here. Nobody is born without lungs and lives, right? Yeah, nobody will go home if they are like this. So please don't give these babies hope. There was a time when I was in France, at some point, a case like this was thrown on the group, and people actually agreed that it is better to deliver this baby by C-section, but this is wrong. This is a lethal condition, a total lethal condition. You cannot offer C-section here with giving the woman hope. There are no lungs here. No one walks in the streets without lungs. So this was a rare case of what you described as a heart failure, severe preeclampsia case. Look at this heart. You can see it's quite globular. Look at the ventricles. Everything is now dilated. It's a dilated cardiomyopathy. We now have pleural effusion. You can see the lungs hanging. And these were the ductus venosus. You can see there's now reverse. The heart is literally failing from a case of severe placenta disease. This one, another 4-chamber. You can see it's feeling nice. Look, the heart looks small. It's smaller than it should be. We said it should make up at least a third. This is not a third of this thorax. The lungs are looking like they're big, right? Because the heart is small. The reason why it is small is because you can see it's filling nicely on the right there. The right ventricle is filling nicely with blood, but the left has a very small flow going through this VSD, big VSD there. This was a case of hypoplastic left heart in one of our ladies. She came at 16 weeks. We saw this at 16 weeks. Yeah, it was around 16 weeks for this one. So this is how you can recognize some of the defects. I think I will stop here. I don't think I should continue. I wanted to cover 4 chambers. I'm not going to continue with the can I show you one image of AVSD? Where is it? Right. So look at this image here. You can see that the 2 valves are opening and creating a common channel. This is what we mean by common AV canal, which is AVSD, right? You can see that as they open, they're opening a common channel, which should not be the case. You can see there's a large VSD and an arterial component of the septal defect as well. So this is a case of AVSD. You can see even the way blood is flowing, that is going through a common channel and filling the 2 ventricles. What is happening here is that the ventricle, the valves, there are actually 5 valves that are around, because there's no middle structure to insert the septal leaflet. So we have 5 valves that are going right around the atrial ventricular junction, and they are opening all at once. These are some small VSDs. Right, I think I'll stop here for the heart. Quickly, I'll just take you through the quiz again, so that you can, from what I've presented, I think you should be able to figure out 1 or 2 things there. Let me see if I can bring back the quiz. To just bring back the quiz, let's see. Oh la la. I think it's still opening this Microsoft. I don't know if you can see my screen, but the quiz is taking time. I think for the sake of time, I will hand over to Mr. Zanga. Then we'll entertain all your questions at the end. Mr. Zanga is the last speaker of the day. I will hand over to him to start his talk. Then if we have time at the end, I'll show you the quiz. So Mr. Zanga, you can go ahead. Then if there are any questions in the chat, I will attend to them. So Mr. Zanga is a sonographer, specialist sonographer. He's one of the fetal medicine fellows, one of the fellows who started with us in fetal medicine. He's a specialist sonographer and is a lecturer with the University of Zimbabwe, and has been a student of placenta disorders. Is currently doing a PhD looking at fetal growth restriction, the issues of Dopplers. So he's a real student of placenta disorders. So today he is going to present to us on obstetric scan, just basic approach. He will highlight some very important points that most people probably may not be aware of, or you take for granted when you are doing obstetric sonography. So Mr. Zanga will come in and address all that, so that we are enriched as we see pregnant women. Please go ahead, Mr. Zanga, once you are ready. We can see your screen is coming. It's taking time, but it's coming. Are you okay with your screen there? Mr. Zanga, are you winning? Do you want to speak, to say something so that we know you are there? Maybe you want to unmute yourself, just unmute yourself and speak. While he's coming, let me see. Right, I'll address some few questions here while he's coming. The first one, I don't know if Simba didn't answer the question on acrania. It's not a neural tube defect according to the literature. Acrania is a continuum of anencephaly, and we classify it as an open neural tube defect. I don't know what literature, Justin, do you think acrania and anencephaly are two different conditions? If you can answer that question, I think we'll have the answer to that question as well. But we understand that acrania is a continuation, is the beginning of anencephaly. No baby is seen without a brain at 11 weeks, including those you will not see the brain at 36 weeks. They will be having the brain. What they will be missing is the skull component. So if you could answer that one, then I think that answer will be, that question will answer itself. Then how can we differentiate fetal heart block and atrial fibrillation? Very good question. Normally in atrial fibrillation, it may be difficult to see to see some of the waves passing through when you do pulse wave Doppler, but the atrial fibrillation is likely to have a very high rate of the atrium compared to the ventricle. There is a component which I didn't mention when I was doing the fetal heart because I thought it is beyond just routine, because sometimes if you want us to do the right fetal heart examination, that routine, if it becomes too complicated, sometimes people will give up before they even tried. So I try to simplify it, but what happens is that the arterial and the ventricular rate should always be measured separately and compared, and see if the arterial rate is of any multiple to the ventricular rate, for you to be able to see that the atrium is discharging probably at a faster rate than in the ventricle, or that there are some more of the waves which are not passing through, which are supposed to pass through. So yeah, probably that's what I could say. Heart block, very easy in terms of differentiation. Like I showed you on one of my images, that the easy one, which is easy to distinguish the complete heart block, of course, where you will see that there is no matching between the atrial and the ventricular rate. They are not communicating to each other. That is very easy to determine. Mr. Zanga is trying to restart the machine, so I'll be going through some questions, and please clarify on the angle between the foot and the tib and the fib. Simba, you should answer these questions. If you are available, please answer the question. There is a question in the chat box. People want to know, how do you distinguish? How can you say there is club foot, there is no club foot? Just few questions while Mr. Zanga is sorting out his machine. So what is the abnormality here? You can answer yourself, but I've already told you that there is a fetal bradycardia due to a heart block here. The heart is not beating the way it should, as you can see. Then the next one, what condition is this? What can we see? We can see a dilated atrium. We can see a dilated ventricle. We can see a very thick dysplastic septal leaflet of the tricuspid valve. And we can also see that the left side is dilated as well. So this condition is Epstein anomaly. The next one, oops. So the next one, list the abnormalities. There is an AVSD here. Then the atria look symmetrical. They don't look normal. So we thought there was a duplication of the left atria here, so that we had left isomerism, because they look symmetrical, they don't look morphological left and right. So, and we can see two vessels here. I told you that you should never see two vessels here. The other one was the azygous vein. So there was also interruption of the inferior vena cava for this baby. So our diagnosis for this one was heterotaxy with left isomerism, of course, with all the other defects which I showed. You can also see that the heart is deviated more toward the left. The angle of the heart is not normal. And the beating as well. The reason why they beat like this is because they will be missing the sinoatrial node. Remember, the sinoatrial node is in the right atrium. So if we have duplication on the left atria, the sinoatrial node is missing. So they beat closer to the ventricular rate, which is a very low rate. Normally it's under 100. Sometimes they'll be around 100. Sometimes they can go as low as 60 or 50. Unfortunately, in our setup, this condition is near lethal. The ones we have had, none of them have gone home, unfortunately. Even the pacemaking will not help here. So, because they'll be having other defects. Remember, heterotaxy, for those who know pathology, that heterotaxy is not this which we see. Even on the lungs, they won't be having 2 and 3 lobes. You could have duplicated 2 lobes. Then on the intestines, there could be malrotations. They have a lot of other problems. They could have problems of respiration, ciliary disease, because it's to do with the traction and the movement at the micro level, so that organs don't move the way they should. So as a result, they have other things that complicate their lives, these babies. The last one, I think this is the last I showed you. Yeah. The other ones didn't play. So here we can see that the heart is pushed. Looks like a small heart. I'm sorry, this is not the best of our images, but you can see there's an AVSD here, a common opening on this heart. There were other things, but I didn't show you those. So I'll not talk about those abnormalities. So yeah, so if you manage to get anything from this quiz, then which means you are not, you should be scanning the heart, and you should attend our fetal echocardiography course, especially if you got half of what we showed you here. Then you need to pursue your skills in examining the heart. That means you have this goodness about knowing the heart, and you can even become better and be a fetal echocardiographist. So